Welcome to the last episode of atrial fibrillation, in which we will learn about the management, and if you'll stick till the end, we can learn about a fact which is less known. Suppose you get a patient of atrial fibrillation. What is the first thing that you need to do? You need to check the ventricular rate. If the ventricular rate is less than 100, the patient is hemodynamically stable. You can just rehydrate the patient if he or she is dehydrated, and the anticoagulation will depend on the CHA2DS2-VASc score. I'm guessing you all know this by now. This can take a quick turn if the patient is presenting with atrial fibrillation with RVR, meaning that the ventricular rate is greater than 100. In those cases, you need to look at the patient whether he is hemodynamically stable or unstable. If he is hemodynamically stable, you can go ahead with the rate control with calcium channel blockers and beta blockers. If the patient is hemodynamically unstable, you have to do cardioversion. Now for the bonus points. If the patient of atrial fibrillation has atrial fibrillation for more than 48 hours or for an unknown period of time, you don't know whether he or she has an embolus or not. So before doing cardioversion, you need to keep him or her for 3 weeks of anticoagulation, and then only you can give cardioversion. But for some reason, if you need the cardioversion to be earlier, for example, in pregnant women or in symptomatic patients, you can always do a bedside TEE to detect the embolus earlier. And with that, we have learned the management of atrial fibrillation. Don't make your heart race once you see a question of atrial fibrillation, because now you know most of it. So follow on course and save this video for more such content.